I'm delighted to have Ruth Carlyle with us, Queen of the Midlands and East in Health Education England and all things health literacy. Thank you very much, Ruth.
And thank you very much for the warm welcome and for the warm-up from the previous speakers, which does actually mean that I have a lot to live up to. Now, I think you've probably all just got in and feeling a bit settled, aren't you? You've had your coffee, etc. I'm going to ask you now, if you're able to do so, please to stand. Okay. Now, if you have a degree in classics, so Latin or Greek, could you sit down, please? Ooh, ooh. We do have one. If anybody has either Greek as a first language or a good understanding of Latin and Greek, even if they don't have a degree? Okay. Anybody have an A level in either ancient Greek or Latin? Ooh, gosh, we have such a literate lot here. Anybody who's got GCSE, O-level or equivalent in terms of Latin or Greek? So actually quite a few of you. Now look around. See who these able people are within the community. Because these are your guides if you're going around a hospital. Because actually, if you look at the really appalling signage that you get in most hospitals, actually most of it literally is in Greek or Latin or an amalgam of the two. So you get lots of things like oncology and radiology. And actually, for this example, if you were going for an X-ray, now A, it's very, very difficult to read. This was the best screenshot I could get of it because you can't stand sufficiently back to read the thing to begin with. But actually, it's got all sorts of different things all melded together in terms of mixtures of things which are names of wards, so Cedar Ward and Marjorie Warren, who I'm sure was very eminent in terms of ward names, etc. But also you then have things like imaging and X-ray. So if you go for an X-ray, do you go to the imaging department? Do you go to the X-ray? Do you look for something radiology? It is very confusing. So what we're going to be covering is actually to do with health literacy. And its importance is actually quite fundamental in terms of how it is that we approach the services that we use. You may now sit. So if we're thinking about health literacy, it is actually something which is not just about you as an individual or a patient, whatever that means in terms of language. It's about how systems, how structures work, and how it is that we're able to make the best choices in order to make our lives as effective as they can be. So as the previous two speakers have alluded to, there is something about how it is that you have your information literacy, your ability to access information and appraise it, applied specifically within health, which means you really are making life and death choices. And very sadly, one of our hospitals within Midlands and East, which is the region that I'm based in, has just been through a court case because very sadly, a patient was discharged who didn't understand the instructions they'd been given and didn't take their medication as instructed and very sadly died. So this isn't just a nice to have. This isn't just about getting better marks in a paper. This is actually fundamental choices and decisions that people are making. So if we think about health literacy and how we might define it. So this is a definition that's come through from the World Health Organization. Now, if you look online and do a general search, you will find that there are two main definitions, one from 1998, and this one's the 2015 definition. There's a link at the bottom of the slide, and when you come through, you'll be able to click on those to get through to the 2015 definition. What's interesting about the evolution, if you like, of health literacy as a concept is that the 1998 definition was very much around how it is that individuals can make choices, take responsibility for their own health. Whereas, whilst it's a little wordy, this is a bit more holistic. So it's not just the personal characteristics and social resources needed for individuals and communities, but it's actually ensuring that the services themselves enable people to make decisions about their health. If you're thinking about it in terms of the elements within that, so some of it's about accessing. So that relates very much to the information literacy, but also in this increasingly e-health era, where we are all, according to the NHS long-term plan, to be offered digital or online appointments within the next 5 years, having those E and digital resource skills is very important as part of your access. There's that element of understanding. And actually, how have you worked with somebody to ensure that you've supported them to understand? Because if they don't understand, that's your fault because you didn't communicate it properly. It's not the fault of the person to whom the information was being communicated. There's then appraisal, which actually, as specialists within library knowledge services, whether that's within academic or whether that's in NHS or schools or whichever sector you're in, we're all involved in that appraisal. That selection, that ability to be able to review the bias of different sources, etc. And then the fundamental element that perhaps makes it slightly different in terms of health literacy is then you're using it. So you're then making decisions that enable you, for example, to work out that actually if something is described as being take 2 hours before a meal, you do take something 2 hours before a meal. If something is described in terms of a choice about physical activity, that actually you are moderate level of activity for 150 minutes a week, and you know what that means for you, as opposed to it just being a theoretical description. So what's the scale of the issue? Now, probably you will have seen this statistic previously, but it never ceases to shock me. This is work that Jill Rowlands published in 2015. There's a slightly earlier version of it that came out as a letter in the BMJ 2 years earlier. The example she used in the BMJ letter was actually to do with children and having adults unable to understand paracetamol medication. So this 43% of adults not being able to understand textual information. One of the resources that was used to assess that was actually a paracetamol leaflet from a standard package, and that 43% of adults could not understand sufficiently well to give the correct dosage of paracetamol to a child. So if you think of that just in terms of day-to-day, this isn't just to do with a significant medical diagnosis, this is just day-to-day living. The elements in terms of the data itself that Jill Rowlands presented, we have 16 to 65 because those were the data sets that she had available to her. Now, there's a reasonable supposition that if you're looking at your 65 plus, actually the health literacy levels may be even lower. Partly because people get confused, partly because actually in terms of power relationships, the relationship between a member of the public and somebody in a white coat may be much more distinct for somebody in a slightly older age group. So don't assume that somehow health literacy goes away when somebody reaches 65. You'll see there's also some degree of variation in terms of region. We're actually working with Jill Rowlands and a colleague of hers, Sir Graham Moon, based down at Southampton, to see whether we can get something which is down at a borough level, so that we've got a much clearer sense of actually where are the differences. Because sometimes you do need to know specifically at what particular level you need to be looking at, so you can actually target an intervention to help people. So this is major. That's just with the words, okay? As soon as you start adding numbers in, it gets even worse. So we now have 61% in terms of your national average, in terms of not understanding, as opposed to 43%. So this isn't just a minority issue. This is most of us. And it's most of us at different points in time because our literacy levels will vary, and we'll come on to this in a moment. It means that if you're working in an academic institution, that actually some of the students will struggle when they're thinking about their own health and well-being, because there's something about how you cross-apply issues that you could deal with perfectly well theoretically when you were doing medical studies, for example, and then thinking about it for yourself, actually a slightly different issue. So it may sometimes be about the well-being of your students, be they medical students, nursing students, as much as the well-being of the people for whom those students are caring in the longer term. So it's a continuum. You will see various references to levels of health literacy. Levels is helpful, but I think sometimes underestimates the fact that actually we all have different forms of health literacy and different experiences of health literacy at different points in time. I would say that of these levels, the first and the third are probably the ones you're doing day to day. So if I just go through them, So functional. This element of actually being able to, find it. In a digital era, finding the stuff that's current as opposed to the stuff that's out of date. But some of it's actually very basic in terms of, could you read the appointment letter? Now, that's not just about you as a patient, it's about how that appointment letter was written. Does it actually have the current name of the building as opposed to an older name of the building on the hospital campus that you're supposed to go to? And this is a very real issue in terms of actually how it is that people don't find where they're supposed to go for appointments and then do not attend because they literally couldn't find it. So it's not just about the individual, it's about the system. Some of it's about understanding time. So for some people, if you say, well, actually, we've made an appointment for you at 9:40, and they're just about to go away, and then you say to them, oh, we'll see you at 20 to 10. You've actually described the same time in a different way. And for some people, that is confusing, and they no longer know what it is that you meant and when it is they should be coming. So there are lots of people who struggle with quite fundamental issues in terms of functional health literacy. If we go on straight to the critical and then back to the interactive, as professionals working with content, working with academic and other sources, you are dealing with critical literacy issues on a day-in, day-out basis. So it's the ability to read critically and to challenge sources so that you can actually bring together from different perspectives. And when we were thinking about the academic literature and literacies earlier on, you can do your although and informed by in a quite clear and concise way. You're able to compare different sources. We then have the interactive. Now, the interactive may not be such a day-to-day issue for library knowledge services yourselves. This is the ability to make decisions, to act on. But this is fundamental to where you have your one-on-one professional and member of the public interaction. It's also where we all are day-to-day in terms of our self-care, whether that's in terms of keeping physically fit, or whether that's in terms of how it is that we make sure that we are reducing our risk of heart disease and those sorts of things. So interactive tends to be more personal. You may not be dealing with it on a day-to-day element yourself, but there's lots you can still do in terms of supporting with the skills to enable others. So I mentioned it's a continuum, and actually levels change. So this is Tricia Greenhalgh, who literally wrote the book, didn't she? How to Read a Paper, An Introduction to Evidence-Based Medicine. She literally wrote the book in terms of the practice around evidence-based practice. And yet for her, when she was diagnosed with breast cancer, the first thing that she did was to put breast cancer into Google because she was frightened. So if somebody at her, I would say, highly advanced level in terms of her literacy, in terms of her ability to comprehend information, at that moment of shock, felt that actually she needed to reflect, she needed to go back, she needed to almost regroup her whole sense of what she understood. She was going right back down to the functional. And using Google, well, there are other sources, aren't there? So there is that whole sense in which actually for all of us, we can get undermined. So I'm actually going to share a personal experience because sometimes it is the stories. And if you're talking about health literacy, there's something about being open oneself about what it means in terms of being health literate or not being health literate, because actually we all have different elements at different points in time. So my experience in this particular instance relates to my eye health. So I have a condition which is called optic nerve drusen, which is moderately rare. I mean, it's sufficiently rare that most opticians will never have seen it. It means that if I go to an optician, they have a tendency to look at the back of my eyes and freak out and try to send me to A&E because I think I've got a brain tumour. Basically, the optic nerve is expanding because there's a little bit too much calcium and over time it grows. When I had an interaction first time around with an optician who tried to literally to send me to A&E, at that point in time, I would say that my health literacy was completely thrown because I was somewhat shocked. I was not expecting to just go for a standard eye test and be told that I might need to go immediately to A&E and that they would see whether they get an urgent referral through to the eye clinic for me. So there's that whole element through. Happily, they triaged through in terms of, and they spoke to a triage nurse who said, actually, it's probably not, she's not getting headaches or anything like that, probably not. When I did get to the eye clinic, I've had what I felt was a very good interaction with the consultant, because what she did was she checked my understanding first. So she went through with me in terms of showing me what the slides looked like and how it is that actually an optician might misread my signs and symptoms. She then asked me to describe how I would tell an optician what it is that I suffer from. So whether I had the name. When she checked that, she asked whether I knew whether the records would be held. Burton Hospital, very exciting for those of us living in the Midlands. But also whether I had any sense of what terms I'd be looking for in terms of if I wanted to know more myself. So it felt as though that, from a professional perspective, she was giving me the space to say I don't understand, but also the space to acknowledge in terms of how it is that I would tell somebody else. So she wasn't assuming that I knew. What she was doing was she was asking me how I would tell an optician so she could check what I understood, and then she would have reframed if I'd needed it. So we're now going to do something in terms of what it feels like. Now this may be a little uncomfortable. There is something about health literacy that is profoundly unsettling for all of us, because we are making what could be life and death choices on the basis of whether we understood information or not. So I'm going to do a little test with you. So, exam conditions: you are not allowed to confer with any of your neighbours. If you have a pen or paper or a digital device, you're going to write down the answer. Once you've got the answer, if you could just sit with your arms folded and perhaps lean back a bit, that'd be really good, because that indicates to me really clearly who's got it, etc. Okay, so I'm feeling generous, so, I'll actually give you 60 seconds, I think, which is very generous, because it's very, very easy, and I'm sure you'll all get it immediately. Okay, are you ready? Pens? Everybody got a pen, or they've got a digital device so they can actually write something down? Okay. So we now have 60 seconds, starting now. Okay, I can start these countdown now. So 10, 9, 8, 7, 6, 5, 4, 3, 2, pens and papers down, please. Okay, so who got it? Absolutely. And that is part of the issue. It's deliberately chosen as the bass clef because I thought there might be a female dominance within the room. That might make it a bit harder. Is it facade? It is. Very good. Because I was playing around with the octaves as well for those. So our code is the music code, basically. So music is a language. You either understand it or you don't. As Isla's mentioned, actually, some of us understand bits of it and some not. I'm soprano. I'm very definitely treble clef, not the bass clef in terms of singing. So there is that element in terms of we may understand partially. There are some people who will get it immediately. And actually, that's brilliant. But for some other people, actually, you might think about that in terms of what that implications are. So it is the word facade. Okay. So how did that make people feel? Did anybody enjoy it? Okay, there's always one. Did anybody feel irritated with Ruth, with me, in terms of thinking, why is she making me do this? Probably. There will be those elements through. Anybody feel actually that just wanted to disengage? I'm never going to be able to do this, so why bother? What's the point? Any things about that? Actually, what's the point of this? Or even feeling angry? These are all reactions that people have when they don't understand information. Quite often people close down. Quite often they will find coping strategies, and strategies which may not be immediately obvious. Some of this is not just health literacy, but it's literacy more widely. I used to work with Macmillan Cancer Support, and in one of the local information support services, we had a gentleman who came in every day with the Telegraph under his arm. He would take out the Telegraph and he would open it and he would flick through the Telegraph each day. He was about to have surgery to remove the voice box because of his cancer. The day before he was due to have surgery, Sonia, who is the information manager, went to chat to him about one of the articles in the Telegraph that he was reading, and it became apparent that actually he couldn't read. And all of the interventions to help him to communicate after his voice box was removed the next day had been predicated on him being able to not only read but use a keyboard. So there is something about we cannot make assumptions. In that particular instance, actually, she was able to arrange for his surgery to be delayed, and therefore they were able to get other communication aids. Not brilliant, but at least they were based on pictures as opposed to being based on text, and they were things that he could use. There is something quite fundamental about issues around health literacy and its full spectrum in terms of information and literacy in its widest sense. And we cannot make assumptions, and we cannot assume that we will always be able to cope ourselves. Because at the point when actually you're stressed, particularly if it's a diagnosis such as, say, cancer, then for everybody, your literacy does go down. Coping is difficult. And a lot of what we can do in terms of library knowledge specialists is actually how do we help those around us to cope with those dips in health literacy, to make sure that we actually deal with those effectively. So in terms of implications, so we have some things which are actually to do with misunderstanding. So if you're provided with information, you might say yes, no, because that's what you think the person wanted you to say, and you might not have understood it. And it may be that actually what you as a patient have understood and what they as a professional have understood is completely divergent, and therefore you're not acting appropriately. It can lead to poor decisions, so people not making the decisions that actually are best for them in the widest sense. If you're thinking about decisions about medication, they're not straightforward. So, for example, if you have somebody with multiple sclerosis, they might need to make a decision in relation to medication for spasticity in the legs. Now, this isn't straightforward because sometimes if you have very low mobility, having the spasticity is helpful because it enables you to be transferred from a bed to a wheelchair, whereas if you're all floppy and you're quite heavy, then actually nobody else is going to be able to help you to do that unless you have a hoist. So the decisions are actually quite complex. They're not just to do with did you understand what the medication is and how to take it. It's about actually what's the decision in terms of what this means for my life. It can exacerbate inequalities. So whether it's older people, whether it's people for whom English is a second language, actually, because time hasn't been spent with them in terms of their understanding and their decision-making, they've not made the choice that was right for them, and therefore they can't act appropriately. So you get clusters of people making very bad decisions, whether that's in relation to, for example, Asian women making decisions not to go for smear tests because they associate it with women who are having multiple partners, or whatever it might be. There's all sorts of things where people actually have poor decision-making and therefore it exacerbates inequalities. Inappropriate use of medication. So you get all the classic things where actually people spray things that they shouldn't spray. Most people can't use an inhaler appropriately. Unless you explain that an inhaler has to go down the throat as opposed to on the throat, people aren't going to use it appropriately. Ineffective access to health services. If you couldn't find where to go for the X-ray, then actually your medication could be delayed. It could be that actually tests are delayed by a month before you get the next appointment or more. If that's cancer, that can be quite significant, and poor health outcomes. So what can we do? How can we help? Because actually, as those of us who are working within library knowledge services across a range of academic and NHS sectors, there's quite a lot that we can do. Some of the resources that we can use are all on the Health Education England website in terms of the toolkit for health literacy. Now, this brings together a range of different resources. It starts with, wait for it, your business case. It may sound very prosaic, but actually you need to have an easy model in terms of how you might get some funding to make things change. It includes things like guidance in terms of how it is you might run training sessions, case studies. In this particular instance, they're mostly case studies from the East Midlands because that's where a lot of the work was done initially. And it also includes a how-to guide. So it's definitions, issues in relation to how you deal with general communication, verbal communication, written communication, and lots of links through to different elements within those. What's particularly pertinent is actually the links through to different, whether it's e-learning or different free resources. They're all freely available resources that are linked from it. You will find lots of references to, for example, teach back and chunk and check. Fundamentally, teach back is where you get somebody to paraphrase back what it is that they understood. So quite often I would tend to use it in terms of how would you describe this to your friends and your family? Something like that. So that you're not actually asking, did you understand this? You're actually getting some sense of not only whether they've understood, but whether they've understood sufficiently well to process it for themselves. We also get chunk and check referred to. This is actually taking very short sections as opposed to having a long spiel. So if you tell somebody about, actually, these are the risks, etc., these are the test results that you had, and these were the medications we suggest, and this is the evidence base around the medications, and this is what we think you should do, without pausing for breath almost, that's actually very difficult for people to take that on board. So literally pausing can help people assimilate through. Quite often you get your chunk and check used alongside the teach back. So you're effectively doing a little bit in terms of people's understanding, then chunking and checking that bit in terms of the teach back, the next bit through, and then you're checking with them again. I've actually given you that in less than a minute, but actually there's lots of e-learning courses where you can spend hours doing that if you really would like to. Potential roles in terms of library knowledge services. Some of it's about raising awareness of the issue, the techniques and the resources. These are core library knowledge service skills. For those of you who are working in partnership with NHS services, some of it might be about identifying potential sources in terms of patient information materials, or it may also be in terms of doing the evidence base to make sure that actually patient information is accurate. A survey that was conducted in a trust in the West Midlands earlier, well, actually, very end of last year, people were asked about the evidence base of the patient information they used. The majority of respondents actually skipped the question. So not only did they not know, they hadn't even really thought about whether or not patient information should be evidence-based. You can assess what it is that your service does in terms of whether it's health literacy friendly or not. And this is in any sector. So written communication. Do you actually describe your library knowledge service in a way that people understand? Do people know what an interlibrary loan is, for example? Or is it just getting a book from another library or a resource from another library? Do you have, in terms of your spoken communication, do you make it absolutely clear that it's okay to ask? Or do people have to come to you and feel confident to ask? Or do they think they can only come and ask if you're at the desk? Or how is it actually worked through? In terms of the stock, is the stock all pitched at the same literacy level? Or have you actually used some of the guides and resources in terms of assessing different reading ages in terms of literacy level for information materials? There's also signage. So I used the example of, it's an East of England in the hospital, their sign, and actually it was quite confusing. But actually, is your signage in your library any better? Would people be able to follow it through if they'd never used a library before and they were unsure? So training. In terms of the awareness of staff, actually are people within the service itself aware, but also do you offer training to others? If you're offering critical appraisal training, actually you can add in health literacy quite easily into that without it feeling as though it's something which is an imposition. Because it's in the interest of whoever you're working with that not only do they understand the information, but anybody else that they're conveying that information to understands it. There's also the policy dimension. Now, that might be a policy for the library itself. It might be the policy for your overall institution. But actually, do you know whether your institution has, A, reviewed its policies to make sure they're easy to understand from a health literacy perspective, or B, actually have a specific policy around health literacy? So you can make some very simple changes and actually improve the access in terms of your own service. In terms of knowledge for healthcare, This is the strategic framework for library knowledge services within the NHS, but I'd like to think that it's also something in terms of our partnerships within academic and other libraries that's relevant through. We've just coming towards the end of the first 5 years of a 15-year framework, and we are discussing this in terms of what that means for the next stage. We are sure that there will be things around patient information and health literacy as part of that, building in part in terms of the really good work that's already happening around information literacy. We're also in the position of being able to build on the TOPOL review. Note the pronunciation. I understand that Dr. Topol for months was going around and being introduced to people as Dr. Topol until he said his name himself, and actually he's Dr. Topol for the TOPOL review. And for those of you who haven't read it yet, there are lots of different references within it to knowledge specialists. That's us. It requests that actually there are increases in us. It talks a little bit about e-health literacy and about health literacy in one of the case studies, lots of things about digital literacy. These are all opportunities for us in terms of how it is that we make sure that we represent information in ways that are understood and help our colleagues to enable patients and the public to understand that information. So this is me. So I'm Ruth Carlyle. So do feel free to follow me on Twitter or whatever. Just a warning, if you do follow me on @rcarlyle, there is a lot about music as well as being stuff about library knowledge services. But that's probably not a surprise after the example that I used earlier. So thank you.